Okay, let's move on. So this is an algorithm of how to do a CPAP titration. All of the rules we've just covered are basically displayed in front of you. You just have to know how to follow the map. So we're going to start in the bottom left-hand corner. You'll see it says 4 centimeters of H2O minimum. So that's our minimum starting pressure. Again, you can start a little higher, especially with morbidly obese patients. Sometimes they just need more pressure, but the minimum pressure you can start with is 4. Okay, now moving to your right, following the dotted line, you see that that is 5 minutes or more of time. So we have to wait 5 minutes with the patient asleep, and during that time, we're going to assess, if you follow the dotted line upwards, we're going to assess, are there 2 or more obstructive apneas during that time? If there are, then we're going to increase the pressure by 1 centimeter of water pressure, or H2O, or maybe even more. Typically, we don't go above 3 centimeters of water pressure in one change. I like even numbers, so I always go up by 2, but some places do 1 centimeter. If they don't have 2 obstructive apneas in those 5 minutes of sleep, did they have 3 hypopneas in those 5 minutes of sleep? If they didn't, did they have 5 RERAs during those 5 minutes? Or did they have more than 3 minutes of loud or unambiguous snoring? So if they met any of those 4 things, then you can go ahead and increase your pressure. Again, you can increase it by 1 or 2 or maybe even 3 centimeters of water pressure. It's up to you. Then as the patient continues to sleep, now you should see, follow the dotted line up one more time. We're going to wait 5 more minutes of them sleeping, and we're going to reassess the exact same things. If any of those are found, we're going to go ahead and increase by 1, as many as 3 centimeters of water pressure. Now, if you go for 5 more minutes and they don't have any respiratory events, then you keep watching. And if they go on to 30 minutes or more without any breathing events, okay, that's that top straight line with the 2 slashes on it. Follow that to the right. Then you try to make sure that you have got your patient in both supine and REM sleep, preferably supine REM sleep. Okay, if your patient hasn't been in the supine position or gotten REM sleep yet, you might need to go wake them up and have them roll onto their back. Once they're asleep again, after 30 minutes without breathing events, if you've got them on their in the supine position in REM sleep, you want to get at least 15 minutes of time of that. If you've got all of that accomplished, you can start down titrating, meaning decreasing the pressure to see if any respiratory events reemerge. That's kind of like fine-tuning it, okay? Now, another option is when the patient has gone 5 minutes or more without any respiratory events, and you continue to watch them, you can actually increase the pressure up to 5 centimeters of water pressure and do what's called exploration of pressure. Again, this is just trying to fine-tune your patient's best pressure. We don't always have enough time in the night to do this, but if you can, it's great, okay? So let's say that we get our patient to a CPAP pressure of 10, okay? And they have gone 5 minutes without any respiratory events at all. And they have been in the supine position in REM sleep. What would our next action be? You have 2 options, okay? You can either do exploration and go up, or you can do down titration and go down, okay? If you have questions on this, please be sure you're asking. Okay, so what if your patient just is intolerant of CPAP? Well, before you can determine that your patient is intolerant of CPAP, you have to first ensure that there are not excessive leaks, which might be contributing to respiratory events. You also want to try C-Flex or ERP. which slightly reduces the pressure on exhalation. That might make them more tolerant of their PAP. Keep in mind that nasal masks require less pressure to treat apnea than full face masks do. So sometimes if a patient is on a full face mask, they need quite a high pressure. If you switch them over to a nasal mask, their mouth might actually go shut once they treat the respiratory events. And so then they would need a lower pressure possibly as well. So sometimes switching interface devices might be the key. However, if your patient is still not tolerating their CPAP pressure, or if you have titrated them up to 15 centimeters of water pressure and you're still seeing respiratory events, those are your two indications when you can go ahead and switch to BiPAP. Okay, and I've given you the general recommendation rules for you there off to the right. Let's read 4.3.1.1 together. If the patient is uncomfortable or intolerant of high pressures on CPAP, the patient may be tried on BiPAP. If there are continued obstructive respiratory events at 15 centimeters of water pressure on CPAP during the titration study, the patient may be switched to BiPAP. Okay, we're going to go down, and I would like you to read the bottom rule, the 4.3.1.2. BiPAP, which includes IPAP, which stands for inspiratory positive airway pressure, and or EPAP, which stands for expiratory positive airway pressure, depending on the type of obstructive respiratory event, should be increased until the following events are eliminated. Those include your apneas, your hypopneas, your ureas, and your snoring. So notice our goal with BiPAP is going to be exactly the same as what it was for CPAP. If we see any obstructive events, that's when we're going to be increasing our pressures. Okay, let's go on here. So let's take a look at a scenario. And we do have a couple more rules over here off to the side, but let's go through this scenario first, and then we'll take a look at those. So my patient is on 12 centimeters of water pressure of CPAP, but they have not been using it because the pressure is too high for them. What do I do? Well, these are the first three questions you're going to ask yourself. Did you try ERP or C-Flex to help them with exhalation make exhalation more easy for them? Did you try the ramp feature to help with them falling asleep? Is their interface device comfortable? Remember, we talked there might be an opportunity to decrease or to change their interface device. Not always is that the answer, but that is something to be considered. Okay, so according to those, let's assume we did all of those. Let's read these rules now and see if we can answer the what do I do after we've done these things. While the literature mainly supports CPAP therapy, BiPAP is an optional therapy in some cases where high pressure is needed and the patient experiences difficulty exhaling against a fixed pressure, or coexisting central hypoventilation is present. You can go on to read, this recommendation is based on two level 1 studies. And it goes on, we're going to skip ahead to the APAP. APAP stands for AutoPAP. So AutoPAP is also a treatment option. However, this was not incorporated in the accompanying review paper since an earlier review and practice parameters for AutoPAP was published in 2002. So what they're saying is AutoPAP really hadn't been established and around and been reviewed by the time that these rules were made, so AutoPAP might be a consideration to try for this patient. Okay, so answering our question, what do I do if your patient is intolerant of their CPAP pressure and you have exhausted all other options to make them comfortable, then that is when you could go to BiPAP or possibly AutoPAP. Okay. Now, there was a phrase in there that I kind of went over and ignored, and it mentions coexisting central hypoventilation. We're going to cover hypoventilation next week, so we're just going to pretend like we didn't see that for right now, and we'll keep going. Okay, on the next few slides, I have your BiPAP algorithm. Just like we went through the CPAP algorithm at the start of this video, Here is your BiPAP algorithm. Now, I'm going to provide that algorithm to you, and I've given you a link to the PDF of the AASM guidelines for this. You can use either or, and then you have these questions off here to the left to answer. Don't worry, I have provided those questions on the following slides, so you can just number them in order and just answer the question. You don't have to write out the question if you do not want. Okay.